They asked me to come and talk about my experience of using custom stems. So I just really wanted to take you through my sort of experience of learning, what these stems can give you and what kind of patients I've used them for in my practice. And I think it's been really interesting listening to the other speakers. There's a lot of similar messages that obviously the guys that have had longer experience of using these stems, I've had exactly the same feelings. And I'll go through that when we talk about some of these cases. So I started using this stem in 2015, and now I've done about 14, 3 of those being bilateral. And again, you can see the mean age is pretty young, so it's the same kind of group of patients, these young adults and children. I've done 7 cases, sort of age under 17. 2 of those are bilateral, and that's really where I started with this implant. And I'll show you these cases, 2 cases with bilateral hips in Morquio syndrome. I currently haven't had any revisions yet or any post-op complications as yet, but as we've mentioned, this is a complex group, and that is expected over time. I've got a further 8 cases in planning, so the number of cases seems to be growing as we get experience. But I just wanted to sort of take you through my first case. So I'd like to introduce you to Lily. So Lily is there in the wheelchair. She's 14. She's got Morquio syndrome, mucopolysaccharidosis type 4, for those of you who's doing the exam. I'm sure Akash and Naveen would have picked that one up. So this is her actually outside Parliament campaigning for enzyme replacement therapy, which is a really transformational treatment for some of these kids. But Lily was referred to me by my friend Anne, who I went to medical school with, who is now a paediatric orthopaedic surgeon at the Children's Hospital in Manchester. So she started referring me some patients. So Lily, as I said, she's 14 years old. She's got bilateral hip pain, maximal analgesia. She's been having regular hip injections to try and keep her going. But she's in a wheelchair most of the time, electric wheelchair at school, really struggling with any kind of independence. She just can't, she's just not a normal child living a normal child's life. She's got a lot of other problems. She's obviously had 8 plates in to try and control the growth of around her knees, and she's actually got pretty straight knees. But she does have hyperlaxity in her lower limbs, and as an example of that, so with the hips at 90 degrees of flexion, she has 70 degrees of internal rotation in both hips. She's really, despite the fact she has a lot of hip pain, she has really quite severe hyperlaxity. So these are her this is a plain X-ray, and as you can see, she's really, not really developed femoral heads very well at all. But you can really see the narrowness of the canals on the femurs. So this was, I saw this case and thought, well, from my point of view, I think this is a patient that actually would really benefit from hip replacement. She's really limited by her hip pain, and otherwise was, obviously had other medical problems, but would really be potentially improved significantly with hip surgery. So it's a lateral view. So standard templating, and I am a strong advocate of standard templating, in every hip that I do, but obviously that's, in 2 dimensions. But you can see here that the standard templating, so we use the C-stem system for our cemented stems, and this is the smallest available Asian C-stem, size 0, and you can see distally, it's just too big. This is not going to fit. So that's when I started to reach out to Symbios to have a look at, to see whether or not it would be possible to make a custom stem for this young girl. Her CT showed that the socket actually wasn't so bad. It's small but reasonably good containment. I thought that wouldn't be too much of an issue. And you've seen all these pictures before, so this is the kind of information you get back in the plan from Symbios. And as Callum said earlier, I really defer to the experience and expertise of the engineers in these cases in terms of telling me what they thought was going to work well. And in terms of understanding the various anatomical parameters. So again, the sort of CT planning of the socket confirmed that that was going to be reasonably straightforward in this case. You can see the rotational profile pictures there that you've been shown a lot of. You can see that recurring theme of the neck being retroverted on the proximal femur, and that was the case here as well. So really important to understand that these kind of cases are really complex cases, and it's not the kind of thing, to do on your own. These patients, particularly this particular group, have very poor airways, very medicalized families. Often there is more than one child in a family with this condition. So you really need a combined approach with the pediatric orthopedic surgeons, the experienced anaesthetist, and an MDT type approach. But unfortunately for me, that meant that I couldn't do this operation in where I normally work at Wrightington, and it was a case of me having to go to the Children's Hospital. So I was probably about to do the most complicated primary hip replacement I'd done with an implant I'd never used before in a hospital I'd never operated in. So that was a little bit stressful, but it went well. The first side went really well, and she did really well from that. So we then went on and did the other side. So you can see the sockets were relatively straightforward, and the implants seemed to fit pretty well. In terms of the sort of longer follow-up, so she's now 2 years following the left side. You can see that there's perhaps a little bit of cortical hypertrophy at the lateral side of the distal stem on the left. And maybe there's a little bit of anterior resorption actually around the metaphysis anteriorly on the left side as well. So she's asymptomatic from she doesn't have any pain in that side at all, but I think that's something that I obviously need to keep an eye on. So you saw a picture of Lily in the wheelchair at the beginning of the case here, and this is I really sort of was nodding away when Bryn was talking about the real life-changing effect that hip replacement can have on these kind of pediatric patients with disabling hip problems. So all these pictures are sent to me by Lily and her parents. So I asked them if they would send me some images so that I could, try and get across that real life-changing outcome that you get. So this is just a video of Lily walking. So she doesn't use crutches or anything like that. She's walking pretty normally for a kid with this kind of condition. And you can see a picture of her playing on the beach, painting her own bedroom on a bouncy castle. You can see her rotations. She's got massive range of movement of her hips. And this is just a quote that Lily's mum sent to me. And you just read it through. It's the first time she messed about on the beach. Never been to sleepovers before. Stayed at home. Now she can climb the stairs, sleep on the floor. She can stand to cook. And it says, you see the bottom sentence there, little things, but the difference in quality of life for her and for us as a family has been truly immeasurable. So it's really powerful, actually. So this is the second case. So this is Archie. And again, he gave me permission to use his images here. And he's 15 years old, similar condition, but again, really struggling. He's on CPAP at night times, this lad in his GCSE year at school, struggling to attend, using a wheelchair a lot, really struggling. And you can see by the expression on his face, he's not a very happy chappy. And again, he's got significant, hyperlaxity of his lower limbs, really big rotational range of movement. So his x-rays were a bit more difficult, really. And it was really the acetabulum here that I was sort of challenged by. I felt his femurs were relatively kind of normal, and that I was pretty confident that the Symbios guys would give me a plan for that, but I wasn't sure whether I could reconstruct his socket. Obviously, he's very lateralized. I wasn't sure what this kind of soft tissue tension would be like, whether any hip would actually stay in or whether it would just pop straight back out again. And again, his CT scans there, you can see that there's really not very much, bony containment there. So I really wasn't very confident. But this is when the beauty of 3D planning really helps you to break that down into, to give you an idea whether you're going to get stability with the socket. And actually, it didn't quite look as bad as I thought it might have done. So in terms of his soft tissues, obviously you can see in terms of the leg length and the planned lengthening at the bottom there. So we're planning to lengthen by 2 centimetres, but medialise slightly. So try and keep that soft tissue tension to keep him in. And again, retroversion in comparison to the heliotorsion there, as we've seen on multiple occasions. So again, the operation that went well. And again, I think it's Callum talked about, you do these cases and the range of motion you get and the stability that you get is sort of unlike anything else, really. You've never seen it before. And Lily was the same, and Archie was exactly the same. They both internally rotated about 90 degrees at 90 degrees of flexion on the table. No bony impingement at all. And it makes you realise that if the patient can do it before, they're obviously not getting bony impingement at that position of rotation and flexion. So if you recreate their centre of rotation and therefore recreate the same relationship with the greater trochanter with the pelvis, then they'll be able to have the same rotational freedom without bony impingement. And essentially that's what we're achieving. So they can still get that same stability. So then we plan to correct the other side again, and we balanced him up. And you can see this is, somebody used a term this afternoon, a wonky stem. I quite like that. So that was another wonky stem on this side. And then, so here's a video of Archie walking. So you can see he's a pretty short guy. You can see how floppy his right hand is. He's got such a lot of hypermobility. He's got quite a valgus right knee, but he's walking without pain, without any walking aids. He's at school. He's did his GCSEs the same year as my daughter did, and he's pretty happy. So a few of my other cases are really, I wanted just to pull out some learning points that I've learned from going through this process and experience these cases. And one of the things is something which has been touched on already. It's the shorter hip but a long femur. And this is the result of childhood intervention very often. So this case was a 17-year-old girl. She'd had Perthes, she had a varus osteotomy, again, severe pain. And she came to clinic, and it was one of these cases where mum says she's got a genetic condition, which means she puts on weight. She was quite big, but I don't know whether that's real or not, but anyway. But she was unable to walk, and she had a shit childhood, basically. She wasn't going out, she had no friends, getting a bit depressed. Really obviously would benefit from a really well-functioning hip replacement. And the technical issue with her, obviously, was that she had a clinical leg length discrepancy of only 10 millimetres, despite the fact that the trochanter is way up around the ilium. Standard templating, again, was telling me that pretty much the minimum lengthening I could do with standard hip replacement would be about 2 centimetres. So I might potentially be, giving her a leg length discrepancy afterwards, which she wouldn't be thanking me for. So that's when we reached for the custom design. Again, socket, not too much of an issue there. But I think the soft tissue shadows on this scanogram really show you the crux of the difficulties with this case. So not for the faint-hearted. And in terms of the leg lengths, so you can see that actually, so her left femur is longer than her right femur, despite the fact that it's really short at the hip. So that's when you start really asking for some help for some clever engineers to try and work out if they can help you avoid getting a leg length discrepancy. And you've seen pictures like this. And she actually came to clinic on Tuesday. She's not that long post-op, to be fair. She's only 3 months post-op. But it's a good learning point, this one. That can really help get the leg lengths right. And she's got no clinical leg length discrepancy, and she's very, very happy. And again, her aspect when you see her in clinic now is completely different to what it was before. She's been transformed. This is another issue we talked about. I think Prim was talking about doing rotational osteotomy and shortening osteotomy. Obviously, so my philosophy is to try and make things as simple as possible and not make things complicated. So if I can avoid doing an extra step in the surgery, then I will. But in a case like this, obviously 16-year-old, multiple previous surgeries for dysplasia, severe pain in both hips. Obviously, she's her right femur, which is the problematic side. She has a pseudoacetabulum. But again, from a socket point of view, she's got reasonable superior cover to the true acetabulum, and I thought it would be a reasonable thing to bring the socket down, which was what was confirmed on the plan with a reasonably small socket. But you can see the rotational issue here. So we've got, I think, 79 degrees of heliotorsion in this case. So really quite significant rotation. And I did wonder whether it would be more sensible to do a derotation osteotomy to correct that and bring the trochanter around. But the plan, came back as saying that they felt this was going to be appropriate and there wasn't any significant bony impingement as a result of that. So during surgery, you can see that with these cases where there's so much heliotorsion, your AP X-ray looks like your lateral, and your lateral X-ray looks more like your AP because it's completely twisted around. So that was a good case of essentially making an operation as simple as possible, and therefore potentially and hopefully more reliable. So having done a few cases in weird childhood disorders and other probably more standard childhood problems, I had a little bit more confidence with the system. So use it for a few more cases, and then you start uncovering some unexpected things. And I think this is reiterating some of the findings from other talks. So this was a patient, older patient now, 56-year-old, more like a routine hip replacement, but she'd had previous acetabular surgery for DDH. And I suppose I put these clinical findings up here because I think there's probably a bit of an early warning for what the actual issue was here. So at 90 of flexion, most people you list for a hip replacement, have zero internal rotation at 90 of flexion. They all develop an external rotation contracture. But despite her really quite awful X-rays on the right side, she still had a good 20 degrees of internal rotation. That probably should have been a bit of a warning sign. But that wasn't the reason for getting a custom. The reason was that her femur was actually really, really small. So this was just a sizing issue again. So we asked for a Symbios CT scan, and she actually had 89 degrees of heliotorsion. So despite that X-ray, you wouldn't really pick that person had 90 degrees of heliotorsion of their femur. And that for me was a real sort of eye-opener as, what we don't understand and what we don't pick up from just living in a 2D world. We're like flat surgeons living in an AP pelvis world where we completely forget about the other plane. But this case obviously was a real corker, really. So again, her X-ray is, again, looks like the AP looks like a lateral, and the lateral looks like an AP. And in terms of being her range of motion, so when patients are on the anaesthetic in the anaesthetic room, when we position the patient, I always make a point of seeing what their internal rotation is at 90 of flexion. So I do a posterior approach in every patient, and when I'm testing stability after putting the trial implants in, then I want to know that they can get at least as much internal rotation at 90 of flexion as they had before. So if you have a patient that can internally rotate to 40 degrees, and when you're doing the stability testing, they can only get to 15 before they start coming out the back, then that's not acceptable. But if they had no internal rotation beforehand, and you can get to 10 afterwards, then I'm happy with that. So with this lady, when the anaesthetic was in and we positioned her, she actually had about 80 degrees of internal rotation at 90 of flexion because of all of that anteversion of her proximal femur. So when I did this, I was really worried that, that it wasn't going to be stable intraoperatively. But actually, when we did I put the trial socket in as well as a trial stem because I was a little bit nervous about it. But actually in trial reduction, she still had 80 degrees of internal rotation, and it was absolutely stable. So that's where your lateral looks like your AP because it's so rotated. So the last case really was actually the last one I did, and this is where I had significant intraoperative issues, which I alluded to before when we were discussing one of the other cases. So this was a 40-year-old lady with Down syndrome, bilateral OA, the hips. She was using a wheeled Zimmer to mobilize, was really struggling with pain. And we'd already done the left side for her, and she'd done very well from that. So we planned for the right side to be done. So this is her pre-op X-rays. And it's pretty small femur, so it's pretty tight. So again, the reason for doing a custom was just due to sizing issues here. Shouldn't have too much in the way of version issues, as you can see here. And at the top of the plan, you get some text from the engineers, from the designers. And you can see the text here. Beware of the very dense nature of the cancellous bone. In order to get enough mechanical strength for the implant, we had to design a very filling stem. A distal reaming of 7 to 8 millimeters will be necessary in order to insert the rasp. So that's what that says. So my routine uncemented hip replacement is a cry type stem, so a broach philosophy, and with these smaller implants, I've been tending to just use the broach because that's what I'm used to using. If I can get the broach in, then I'm happy I'm going to get the stem in. I didn't really want to ream unless it was absolutely necessary because I'd be worried about reaming outside the envelope of the design and therefore compromising any stability. So with this case, we did used the broach. It was reasonably hard work to get the broach in, but we got the broach in. I thought, well, that's great. We don't need to ream because we got the broach in. Fantastic. So we got the stem out, put the stem in, and the stem got completely stuck about 1.5 centimeters out of the femur. And it wasn't going in, and it wasn't going out. We worked for quite a long time. I thought, it's got to come out. I've only just put it in. It's not ingrown. It's going to come out. But it didn't come out at all. So I had to do an episiotomy down the back of the femur. So a saw cut all the way down the back of the femur to the very end of the stem, and then just put an osteotome in the top of that, gently tap it in to try and just release some hoop stresses. And eventually we got the implant out, wired it all up, and then reamed it, as it said in the instructions. And then the stem went in okay. Unfortunately, as you can see, I did a psoas release, a lesser track. Unfortunately, it came off, which is a bit of a shame. But the stem eventually, we did get it to sit in the right place. And you can see here on the lateral, you can see the distal reaming that we've done there. And this really highlighted an issue which we've touched on a little bit today in terms of the broach design. So the broach design, you can see the end. These are two different, quite large stems actually. These are the broaches, and you can see the end doesn't have teeth on it. And it's actually the last 15 millimeters of the broach. So whatever the size of the implant, the last 15 millimeters doesn't have teeth on. So if you've got a stem which is only 7 centimeters long, that's quite a big part of the stem. And if we just blow that up, so you can see that the teeth are actually are much bigger than that bullet tip part of the stem. And the teeth are exactly the same as the envelope that the implant will take up. But the tip is not. So the stem is actually bigger than the broach at the end. So this is really, really important. So if you have a case where the tip of the stem is going to be right up against the femur, then you can't just rely on the broach. You have to ream distally. So this really should be a ream and broach technique. And if the engineer is right on the front, you should ream. You should bloody well ream. Okay. So just in summary, what have I learned? So really using these implants and doing custom 3D CD templating has really opened my eyes to the third dimension. And it makes you realize that in orthopedics, you're always told, the first thing you're told is never assess just one x-ray. You always have orthogonal x-rays in orthopedics. So why the hell in hip surgery have we always only had an AP pelvis and thought we could plan everything just on an AP pelvis? Sometimes you might get a lateral, but I don't know what people are looking for in a lateral, but it's not any of the things that we're able to now look at using a CT scan. Use of CT planning, for leg length discrepancy is wonderful, particularly in terms of people who've had previous surgery to look at the segmental difference. Trying to work out the true versus apparent leg length discrepancy in a patient with a fixed adduction and flexion of the right hip when they've had a knee replacement or whatever on the left side, and it's all skewed, and it's not easy. So just scanning them all and measuring it is the ideal solution. And obviously CT is going to pick up these unrecognized issues of version and torsion problems. In my early experience, I was actually provided with some neck cutting guides from the company, which are absolutely fantastic. So that, the stem will fit, but you currently you just measure and make your neck cut. But with a 3D printed neck cutting guide, you get the neck cut in exactly the right place, and that gives you yet another really important landmark to say, if I put my brooch down to the neck cut, then I know I've put it in the right place. So I would, this nudge to Justin at the back, please can we have some neck cutting guides, because they're really, really useful. And I find that the brooch does generally find its own way. You do have to ignore the heliotorted bit of the brooch when you're putting it in, because it just messes with your brain. You just look at essentially the trunnion part and line up the trunnion part an appropriate version to the tibia and make that bit look okay. And that, even if it looks like the stem's going in 90 degrees in a wrong rotation, then so be it. That's where it should be going. And you have to allow it to find its own way. So the positives, the negatives, you beware of the small, tight femur with small implants with it butted up against the femur, and really listen to the advice with regards to reaming from the engineers. I have seen some resorption around above the calcar and some distal hypertrophy. Again, I think that's a distal filling and overload phenomenon, and that needs to be continually reviewed. Prim talked about the brooch holder, and it's a screw-in handle to the brooch. So you only really have rotational control in a clockwise direction. So if you're trying to rotate the other way, it just unscrews. So that's a little bit awkward and difficult. So that could be a possible room for improvement. And what I've learned about the kids is don't be afraid of a big range of movement pre-op. Don't let that put you off. And total hip replacement in PEDS cases really are life-changing. And I always, we talked about counselling these patients. I'm happy to give it a go if we think that Girdleston would also be a good option for this patient. And when you say, well, it's quite a difficult case, and we might not be able to do it, it might not fit, and if we can't do it, we might have to do a Girdleston. Well, how would that be then? Well, it's still going to be eventually good pain relief, and they're in a wheelchair a lot of the time anyway. So I think that has to be a bailout that the parents and the child are happy to accept as a possibility. Happy to receive some help with some other cases that I've got planning. So on the right is a 10-year-old lad with Diamond-Sherman-like syndrome, whose acetabulum only measures 30 millimeters. So we're struggling to find an implant small enough to fit that one. And on the right is another lad with mucopolysaccharidosis, and he's got a really abnormal acetabulum. So we're actually working with another implant company that do custom acetabular implants. That's a double bubble type 3D printed implant. It's effectively a shell with a built-in augment superiorly. So that'll be an interesting case to do. So thank you very much.
Some fantastic contributions this afternoon. I hope you've all had a very fulfilling, engaging and informative day. Thank you, the delegates, for taking time out of your busy schedules to come down to Cardiff to be with us this morning and this afternoon. So keep an eye out for news of HipPLAN 2019. Thanks to Rob and his staff for filming the proceedings. Thanks to the stewards and the Principality Stadium for their efforts today. And also thanks to my staff, Martin, Michael at the back. They worked really, really hard to make this all happen. It's not easy to convene a meeting like this. A few sleepless nights, but on the day, it's been fantastic. So thanks very much indeed. Brilliant.